Good morning, everyone. What an absolute pleasure to see so many of you here. Thanks so much for coming to our annual conference. My name is Craig Morgan. I'm a co-director of the ESRC Centre for Society and Mental Health with Hannah Kienzler. Hannah, do you want to stand up so everyone can see you? And I'm going to do the welcomes and the introductions today. And it is a real pleasure for us. This is quite a moment. The centre has been running now for around about 5 years, so we're coming to the end of the first phase. And today really is about trying to celebrate, or celebrating the past 5 years and all the work that's been conducted, giving us an opportunity to showcase the work that we've done over the past 5 years, that many of you in the audience have done over this past 5 years. And so to have so many of you here to be able to share this with us, to reflect with us, and to look forward is just wonderful. So thank you all so much. As I said, today really is about showcasing the research that we've been doing over the past 5 years. Research that we've done as much as possible in full partnership with people with lived experience, with the communities and community organisations that work daily with individuals affected by social change, by inequalities and by mental distress. And there's a huge amount of work that's gone into this, and so it is important that we get a chance to celebrate that, but also that we get a chance to critically reflect. The research that you'll hear about today is a summary of the very many outputs that we've produced over this past 5 years: research papers, reports, commentaries, blogs, podcasts, and many more. A number of successful PhD students have completed their studies as part of the centre. It reflects, or the research that you'll hear about reflects an approach to working with people with lived experience. It reflects a strong commitment to equality, diversity and inclusion. It reflects a strong commitment to ensuring that we support the next generation of researchers to be able to kind of carry and take this work forward. So thank you for coming. We really appreciate it. In opening the conference, I want to go back to where we started and to go back to why it is that we started this centre. The overall aim of the centre is to conduct transformative research, to inform policy, practice, service responses, to minimise mental distress and ill health, to improve outcomes and reduce inequality. So this is our kind of overall guiding ambition, and the focus of the work that we do is largely on social change, inequalities and mental distress and ill health. And the rationale, the impetus for that kind of focus really came from two observations. So if we go back 5 years, in the years kind of preceding that, there had been a period of quite rapid social change, social and economic change that had transformed many aspects of our lives. The rise in insecurity in many aspects of life, for example, the rise of zero-hour contracts, the gig economy, temporary employment, an increasing polarisation in politics, Brexit, a financial crisis, and on the back of that, a prolonged period of austerity. And I just want to reflect a little bit on this, and just to talk a little bit about the impacts and the effects of austerity and this long period, because the effects of austerity have been such as to worsen the impacts of the initial financial crisis on many subsequent outcomes. And what you can see on this slide is, firstly, here is the decline and the stagnation in public spending over this period since 2010, since the introduction of austerity. And on this side of the slide, what you can see is just one of the possible consequences of this prolonged period of austerity. This line here, going up, is what you would expect in terms of life expectancy if there was no change, if the trends pre-austerity continued. And what you see here is what has actually happened, that there has been a decline in life expectancy. And if you look across a whole range of outcomes, including mental distress and mental health, there's evidence that as a consequence of austerity, that these outcomes have worsened over time. At the same time, in relation to mental distress, over this period there have been and emerged lots of reports suggesting that rates of mental distress and ill health had increased, particularly in some groups, and lots of speculation linking these two trends and developments together. And so for us, it seemed like it made sense to begin to ask the questions of what is the nature of these connections, so that we can begin to formulate policy and practice responses to respond more effectively to these trends. So that was our ambition when we started the centre, was to deliver evidence on the connections between social change, mental distress, to inform effective policy and practice responses. We organised our research in the centre around 3 programmes. And so you'll hear a lot about this today. So you'll hear a lot about the research from each of these 3 programmes. The 3 programmes and the focus was largely driven by the understanding that these groups and these domains were especially impacted by the consequences of social and economic changes. So we've conducted programmes related to young people, marginalised communities, and in relation to work and welfare. And what I'm hoping will become clear throughout, but again to note it, is that from the start, the research that we've done has embodied a commitment to working in full partnership with people with experience and affected communities. It's embodied a commitment to practice and policy impacts, and to using and developing innovative methods, using social science theory to inform the research that we do, and a commitment to ensuring that the next generation is supported to carry this work forward. So, and all of these you'll hear about today. So that's where we started. Within 3 months of the centre starting in January 2020, the COVID-19 pandemic started, heralding a period of huge upheaval, uncertainty, and accelerating even further economic and social change. And this has been followed by an economic crisis, which has seen prices skyrocket, which has seen wages stagnate, which has seen cuts to social security. And the consequences for many have been truly devastating. And in this context, reports about rising rates of mental distress and ill health have simply accelerated and expanded. And it's impossible, almost impossible, to go a day without some report that there are rising rates of mental distress amongst some sectors of society. But we appear stuck with policy responses that focus on expanding access to mental health services, mental health supports, mental health care. And with services really struggling to meet demand, waiting lists lengthening, I think it's fairly clear that that response in and of itself is not going to be sufficient to address the challenges that we now currently face. And so right from the start of the centre, we were faced with pivoting to address both these current challenges and concerns, and also to the longer term trends and changes that we set up the centre originally to address. And so again, across the day, you'll hear both about research focused on some of the more immediate challenges that arose in this context and some of the longer term trends and structural inequities that pattern mental distress and mental ill health. And I think it's important to acknowledge in this the challenge of establishing a research centre at this time. Setting up something from scratch, more or less, in the context of the COVID-19 pandemic, when most of us at the time were locked down, we were all locked down, is only possible with the dedication of a huge number of people, with a huge amount of hard work. And I think it's easy to forget at this sort of vantage point where we are now, what went into establishing the centre and establishing the culture that we hope that we've built in the centre. And I think there's just one kind of thing that I want to flag that comes from that. And that will be another theme that runs through this day. And that is that at times of challenge and struggle, communities do come together. And people do look out for each other. And it is possible to, by coming together and by communities providing support and so on, to flourish. So we hope that this conference is an opportunity to celebrate the achievements, to spotlight the research that we've done over the past 5 years. It's an opportunity for critical engagement with the research that we've done, for reflection, for further networking and building more collaborations, and hopefully for shaping the future direction of the centre as we move into the next phases for the next 3-5 years and beyond. So again, on behalf of myself and Hannah, welcome. We're very grateful that you're here. Before we move into the first session, I have to do some housekeeping. which Hannah very kindly referred to as being like on a kind of flight, and the flight attendant telling you where to go, and so on, which I'm happy to do. But, so if you have any questions, there are people around who have yellow name badges, and they're around to help. So if you have any queries or questions, please do ask someone with a yellow name badge, and they'll be able to help you out. The plenary sessions will take place here. At 11:45 and at 1:45, we have some parallel sessions, and so there'll be sessions here and in the studio on the first floor. Follow the signs or ask someone if you're unsure about where to go. Catering, in the first break, the catering will be served in the atrium just outside the lecture theatre where we were this morning. For lunch and afternoon break, there will be that will be in the studio foyer, and on the first floor, and then back down here into the atrium for networking over lunch. And then just a final thing, the workshop space on the first floor is the quiet space for today. So you're welcome to use this room if you need some time away from the main conference sessions. In that space, we provided other ways of engaging with the centre research. So you'll also find in there other kind of displays, videos, online content. There are headphones with the videos and so on. So please do take some time to have a look at what's on display in that. And again, if you need any other information, then please do ask someone who has a yellow name badge. Okay, so with that, I want to then move us into the first session. So it seems quite natural that the first session should focus on where we started, on the COVID-19 pandemic and subsequent crises, both as an introduction to this session and to introduce several of the themes that will recur throughout this day. What I want to do is briefly present some research that has come from a research study that we've been conducting in South London for a number of years, that we set up around about 4 years prior to the pandemic, but which created a platform that we were able to capitalize on to look at the impacts and the effects of the pandemic. And I think the value and importance of this is that it allows us to highlight some of the themes that I think will recur throughout the way. It allows us to introduce very briefly the kinds of ways in which we conduct research and work, and also to say a little bit about how we then use that information to try to shape and influence and impact on policy. So this study is a study called the REACH study. It's a study of around 4,000 young people in South London who we followed at multiple time points, both pre-pandemic and post-pandemic, collecting extensive information about their mental health and well-being, but also about the challenges and some of the positive aspects of people's lives that they live on a daily basis. And I want to highlight a few things from this. So firstly, before the pandemic started and the information that we collected, what we were finding from this research study was that rates of mental health problems amongst young people in South London were especially high, that they were higher than was the case for the national average, and they had higher than had been previously so in the past. And so just to kind of illustrate this a little bit, here are the numbers, the proportions, who on the measures that we use were deemed to be at high risk of a probable mental health problem. And the overall percentage is around about 19%, around about 1 in 5, with a difference between girls and boys, with a higher proportion of girls reporting mental health problems, probable mental health problems. This here is just the relative risk, so there's about a 30% greater likelihood of reporting mental health problems amongst girls compared with boys. A similarly higher percentage increase amongst those who are in receipt of free school meals. And I kind of flagged this really to just highlight one thing, and that is that rates of mental distress and ill health, they vary over time, they vary by place, and they vary by social group. And the key to responding is to understand what underlies these variations across groups, populations, and over time. We were then able to use this study as a platform to look at the change in mental health as a consequence of, or in the context of, the pandemic. And so hopefully what you can see here is these are the sort of proportions at the different time points prior to the pandemic, so the first time we saw young people, second time, third time. And you see from this that for girls, there's a slight increase over time, for boys, a slight decrease over time. Here's where the COVID-19 pandemic started. And then we were able to collect information to look at the impacts. And what we see, at least early in the pandemic in the first wave, was that there wasn't much change. If anything, there was an overall improvement. Not what we heard necessarily in the emerging report, but I think the important bit about this is that these overall averages mask in wide variation, that some young people did well and some young people did poorly. And again, the key here is understanding why it was that some young people's mental health worsened and other young people's mental health improved. To give a very quick example, young people who had reported probable mental health problems prior to the pandemic tended to do a little bit better early in the pandemic. And the interesting question that poses is something about the nature of schooling and education, which pre-pandemic might have been putting certain pressures on young people and leading to increases in distress, which a period outside of that might have possibly led to some improvements. But the young people who experienced the worst outcomes were, not surprisingly, the young people who were most directly impacted and affected by the negative consequences of the COVID-19 pandemic and the related social restrictions. And all that this is really showing is that there is a kind of linear increase, so that the more negative impacts, the worse the mental health of young people. Not surprising, but important, I think, to illustrate this. And the kinds of challenges that young people faced are listed here, the kinds of things that were the most prominent impact on young people's worsening mental health. And finally, on this part, when we then extended that through the pandemic, as the pandemic wore on, and as we went into subsequent periods of lockdown and social restrictions, there did appear to be a worsening of mental health, particularly amongst girls. And so again, the question it becomes, well, what and why? What were the underlying reasons why in this context some young people were struggling and other young people were not struggling? And so what we did alongside this is we conducted a digital diary study where with a smaller number of young people, we asked them to complete diary entries on a fairly regular basis over an 8-week period to try to understand more about how the pandemic was manifesting in the daily lives of young people. And I'm hoping that this works. One of our researchers, Esther Putzgruber, puts together amazing videos and visuals to capture and characterize the work and the research that we're doing. And here is just one clip from accounts from the diary study.
Because my parents were recently separated, everything was put on my mom, and then you could tell, like, every time I looked at her, I felt like bad or guilty because she was dealing with so much pressure of taking care of so many people in her house, and I wanted to help out her, but like whenever I helped her out, I was missing out time on like studying, and then I didn't realize what an impact that had in the beginning because I was like, oh, I'm just doing something good. I'll catch up later. And then it got to like May, June-ish, and I had like so much work to finish, and I felt like so hit by it. It was so much, and then I felt so worthless and stupid. And I know that sounds kind of like dramatic, but that's what I felt like. And then and that demotivated me further because I thought I was just definitely going to fail, so it was just a waste of like time. And then there was always the looming feeling that one of us was going to get COVID and all of us were going to die because we all stay in the same house, like so many of us.
I should mention that Esther unfortunately can't be with us today, but it's because Esther's getting married. So we can send our kind of collective congratulations to Esther on that. The other kind of thing that this I think illustrates is that that was narrated by one of the young people who we worked very closely with on the research on the REACH project. We refer to as our young persons community champions who have been heavily involved in guiding this research and enabling us, helping us to understand and interpret the findings that we're getting from this. And I think one thing that this clip illustrates is that the waxing and waning of of challenges and distresses over time during the course of the pandemic, but also the ways in which these manifested was really in terms of the impacts that they had on exams and concerns about education and future prospects and so on, and how that's amplified and made even more so in contexts where young people don't necessarily have the same access to digital resources, to computers, to internet, living possibly in conditions that are more cramped and overcrowded. And so on. And so we can see how the sort of broader social context operates in such a way as to increase pressures on particular groups of young people. And so to kind of summarize before moving into the first session proper, what I think this research begins to highlight, and what will recur then throughout themes for today, is that patterns of mental distress mirror patterns of wider inequities. And we see that quite clearly from this. The overall, if we look at the overall effects of crises and change, they can often obscure wide variation. And that variation tends to be that those impacted most are those with the fewest resources to be able to kind of mitigate and withstand the effects of crisis and change. And so to develop effective responses, we need more nuanced understandings of how these crises interact with existing inequities and inequalities to contribute to high levels of mental distress. All the research that we do is to a purpose, and from out of this research on young people, we produced a number of outputs relating to policy recommendations, including at the far end here, recommendations from young people that emerged from a young person's festival that we ran in collaboration with the Big Kid Foundation, which is a charity that works with young people at risk of exclusion in South London, to try to give voice to young people and what they think and what they thought should happen subsequent to the pandemic. So I'm hoping that begins to introduce some of the themes that we will address today and some of the research that we will address today. So I want to now, with that, move on to the first session proper and to introduce our 5 speakers. And I'll do this one by one, but to begin, we're going to begin with Jay Das-Munshi. Jay is Professor of Social and Psychiatric Epidemiology, recently promoted to Professor of Social and Psychiatric Epidemiology. So a pleasure to introduce Jay. Thank you.
Great, thank you. Let's bring this down because I'm a bit shorter than Craig. So is this going to work? Can we put my slides on? It's not quite working. Ah, there we are, sorry. So it's a real pleasure to be able to share these findings from some work that we did at the early stages of the COVID-19 pandemic with you. As Craig highlighted in the opening, in his opening comments, the pandemic actually had an impact on people in sort of subsets of the population. And I'm going to focus in this first bit of the session around how it affected people already severely impacted by mental health conditions. And as you can see, I'm newly promoted to professor, but I'm also a clinician, so there is a bit of a clinical angle to what I'm going to present. So to start off with, let me share this quite, well, sort of optimistic picture of life expectancy in the UK. You can see that in the navy blue, men are in general living longer, women in general living longer too. And as Craig mentioned, there's been a bit of a slowdown coming up to 2019, but generally it's a sort of upward trend. And this data goes back 40 years and ends at 2019, which was a year before the pandemic. Now look at what happens when we think about people with severe mental health conditions. So by that I mean conditions like schizophrenia, bipolar affective disorders. We see that women with severe mental health conditions die 11 to 17 years earlier than the general population, and men with severe mental health conditions die 11 to 17 years before the general population. That's really striking. It's so striking that if you take those spots back 40 years, it's still hugely below the general population. And it's been described by people, by Graham Thornycroft many years described it as a scandalous gap in life expectancy. It's a scandalous inequity. Most causes of death are from common preventable physical causes, We've known about this for decades, and this was a picture just going into the pandemic. And there are lots of reasons for this, which have been many times rehearsed, but I'm going to suggest that underlying a lot of this is essentially the lack of parity of esteem that mental health has with physical health, which derives from the fact that mental health conditions are more stigmatised, and therefore we see discrimination essentially impacting this picture at every single level, both starting at the kind of systemic level. We know that mental health services receive less funding than physical health services, but if you work down the different levels and end with the individual at the sort of interpersonal level, it has an impact in terms of the poorer quality of care that we know people with severe mental health conditions receive. So this was a picture prior to the pandemic. Now, we wanted to understand when the pandemic started, what was the picture? So we did a study using data from just over 160,000 people in contact with secondary mental health services, and we looked across a number of diagnostic conditions, as you can see here. These are age and gender standardised mortality ratios, so we've compared the mortality experience at 4 time points in 2019 across each of these 9 conditions with the general population. And what you can kind of see is that the mortality experience is double, so all-cause mortality, taking into account age and gender, is double in each of these, at least double, in each of these conditions relative to the general population, because they all sit around 2. If you cast your eye to the bottom there, and I can try and point, people with intellectual disabilities in contact with secondary mental health services, it's almost 5-fold. And you can see, so double is the minimum, but actually for some conditions there's a higher mortality experience. Now, of course, we now know what happened. On January the 30th, 2020, the WHO declared a public health emergency of international concern. And this is what happened. So if you look across each of the figures, there's a peak. So soon after the start of the COVID-19 pandemic, there's a rise in mortality, and it's really, really significant. So if you look at the grey lines on each of these figures, that's the experience of mortality amongst Londoners in the general population. So there was a rise in people living in London at that time too, but the excess mortality that we saw in people with mental health conditions was so much larger, and in particular up to 9-fold for people with learning disabilities. So what's driving this? We know that going into the pandemic, deaths from all causes were already apparent, so that's shown in the blue there, but then on top of that, at the start of the pandemic, people with these conditions were more likely to contract COVID-19 and die from it, and you can kind of see that this really played out for some conditions in particular, such as people with dementia in secondary care or people with intellectual disabilities. But this was a concern across the board. I mentioned discrimination. I'm going to just give an example of where I think this played a role. We were in a national emergency at the beginning of the pandemic. There was a massive shortage. It was very difficult to get access to testing. If you cast your mind back for clinicians who are working frontline, we all remember what it was like. And this picture just kind of captures a bit of that. You know, people were using bin bags to cover their clothing because there wasn't enough personal protective equipment to go around. But we also now know that there were some decisions made at that kind of, national, structural, regional levels. We know that mental health resources were diverted from mental health services into general medical services, which I guess, maybe it made sense at the time, but it went on to have real effects. There was a study done by Jill Livingston, which looked at older people admitted to secondary care mental health units who were less likely to, or had a delay in getting testing, and then this had an effect. So people were more likely to develop COVID and die from it if they're admitted to a psychiatric unit for older people compared to the general population. So we failed these groups of people through the decisions that happened higher up that really stem from that lack of parity of esteem that mental health has with physical health. And we also now know that people living in long-term care facilities were also impacted. This wasn't just in the UK, actually, it was in many international settings. So people resident in group care facilities were much more likely to contract and have adverse outcomes from COVID-19 because of the way that these things were managed. When we published this work, it was reported in the press, and there's a headline there in The Independent. I just want to highlight that you might not be able to see it underneath, but the comment that really came out for me was Experts describe the findings as entirely unsurprising, but should be no less shocking for their predictability. So this is kind of even worse. We sort of all knew that this was going to happen, but it was still not avoidable. So I've shown you some data, but I want to share with you now some work that we did as part of the study. So we also we did a qualitative study where we interviewed around 30 or so people across the country who had a severe mental health condition and had long-term conditions. At the time of the COVID-19 pandemic, the early stages, we had some very worrying reports about racially minoritized people being more likely to die from COVID-19. So our study was really trying to tap into that. And this was a piece of work that we did with peer researchers, so people with severe mental health conditions who were on our team, who helped us with the study. We did a short film. The work was led by Josephine Ockley, who you'll see in a minute here. It was widely supported by others, which I'll show you, but a short clip just to share with you what we found. Oh, sorry, if I can get this to work. There we go.
This study was looking at ethnic inequalities in mental health during the pandemic.
The data on ethnicity is really poorly captured. And so with this study, we proactively identified larger scale data sets where we know that information is collected better.
I think the big thing that came up for me is that really quite a lot of our participants were very, very badly affected.
It's like, you're in a river by yourself and you're drowning and no one can help you.
I had no treatment, no medication, and then my dreams were just gone, really.
It was like the hospital just didn't care. It was like my dad was just a number on a piece of paper.
But the problems are not addressed and it's right in front of you. So what do?
We need to stop this failure and support people to flourish and thrive.
So the findings essentially highlight that forms of discrimination are multiple and overlapping and really go on to have strong impacts on people's lives. So I'm going to conclude there by just saying that, COVID-19 magnified the deep-seated inequities that we already knew existed. And I do think that mental health in particular requires special considerations because of the way that in itself, by being stigmatised, it's another level of inequity that we're almost having to work with to begin with. I'll finish by just thanking the Health Foundation who funded the work. Centre for Society and Mental Health have also supported us, and we've had support from the ARC and the BRC in South London. And finally, a bit of a plug. So that was a trailer for the film that we're going to be screening next week at the Brixton Ritzy. It'll be followed by a panel discussion chaired by Larday Smith, who's the president of the Royal College, with Jackie Dyer and some of the other participants you saw in the film. Tickets are free, but if you want a ticket, they're going fast. The QR code to get them is just there in the corner. So look forward to hopefully seeing some of you there. Thank you very much.
Wonderful. Thanks so much, Jay. I should have mentioned that the way that we're going to try and run this first session is that we're going to have all the presentations first and then have everyone up and hopefully a chance for a discussion where you have an opportunity to ask questions or make some comments on what it is you've heard. So with that, if it's okay, we'll move straight on to the next presentation, which is by Dr. Rebecca Rhead. Rebecca is lecturer in Society and Mental Health and is part of our Marginalised Communities research programme. And Rebecca currently works as part also of the TIDES research group examining harassment and discrimination in the NHS and health inequities in the general population. Rebecca.
Lovely. Thank you for that lovely introduction and hello everyone. So yes, my name is Rebecca. I'm going to be talking about a piece of work that I worked on during the pandemic. about ethnic minority staff and the kind of working conditions and things they had to navigate during the pandemic. So just to start off with a little bit of context, we know that ethnic minority staff make up around 20% of the NHS workforce, but are unfortunately underrepresented in senior roles, more likely to face disciplinary action, and have less control of their working conditions. And we know a lot of this from something called the Rhead, the NHS Workforce Race Equality Standard, which was set up by the NHS to kind of monitor the situation and monitor race equity over time in the NHS. So from the Rhead, we know that staff from ethnic minority groups experience disproportionate levels of bullying and discrimination, particularly from other members of staff. So they experience it from patients as well, but they experience it quite a lot from their managers and their colleagues, and that has an impact not only on their kind of mental health, but their career and their ability to kind of work in the NHS. And unfortunately, reports of discrimination and bullying from staff remain quite high, particularly in London trusts. It was going up year on year quite a while in London, and I think it's plateaued now, but it's still a worryingly kind of high level of reported incidents. So obviously workplace discrimination and bullying is illegal, and we know that there is evidence now that shows there are detrimental effects on employees, and we partly know that from evidence from the TIDES project. TIDES stands for Tackling Inequalities and Discrimination Experiences in Health Services. It was a project set up by Professor Stephanie Hatch in around 2017. And during that first phase of the project, we surveyed around 1,000 NHS staff working in London trusts and interviewed around 50, mostly nurses working in London trusts. And we found evidence that suggests that this has a very negative impact on not only their mental and physical health, but also is associated with long periods of sickness absence, low job satisfaction, something called anticipated discrimination. So people who experience discrimination in the workplace are less likely to go on and apply for job opportunities or training because they kind of believe that further discrimination experiences will happen to them again. And we also found through a lot of the interviews that we did that people who experience these kind of things in the workplace tend to kind of cope with them by moving teams or leaving their job, mostly through fear of kind of repercussions from speaking out and fear of rocking the boat. And towards the end of this first phase of our research project, the pandemic happened. And given that we knew that pre-COVID discrimination and poor working conditions were becoming kind of increasingly more prevalent and were quite harmful, we were really concerned that the COVID-19 pandemic would exacerbate poor working conditions for ethnic minority staff. During this time as well, we were very aware that staff from ethnic minorities were also overrepresented in deaths due to COVID. So we thought it was really important to try and find out more about this problem, to try and understand the working conditions for staff during the pandemic. And so we partnered with NHS Check to produce something called the Inequalities Survey, which was designed to assess workplace inequalities during the pandemic. So NHS Check, if you haven't heard of it, is one of the largest UK cohorts studying the kind of psychosocial impact of COVID-19 pandemic on NHS staff. So we worked with them to put together a survey. And we designed the questionnaire for that survey using something called the Delphi approach, which is this kind of interactive consensus-building approach where you work with like a panel of experts over a period of time to finalise, in our case, a questionnaire. I'll just talk you through quickly the steps we took. So first of all, we as a team reviewed all of the available evidence that was relevant to inequalities in the workplace during the pandemic. We then worked with a panel of frontline staff to kind of present that information to them, have really great discussions about their experiences, if it chimed with the stuff we were presenting with them, and to kind of get an idea of the kind of topics we should include in the questionnaire. We then worked with not only frontline staff, but senior staff and diversity and inclusion leaders to prioritise survey questions. And finally, we held a kind of online consultation workshop with stakeholders and people from our panels to kind of discuss and finalise our questionnaire. And from that process, these are the kind of topics that came out. So at the time, a lot of people were very anxious about the COVID-19 vaccine. The experiences of bank and agency staff apparently were very different from staff with permanent contracts. They felt that they weren't always able to speak out. They weren't always given risk assessments, which is a bit of an issue. And a lot of them said they didn't always know where the PPE was during the time. Discrimination experiences came up a lot, not just everyday microaggressions, but more overt acts of discrimination inside and outside of the workplace. Fear of speaking out came up a lot. there was this perceived barrier to being able to speak out, fear of repercussions, which kind of chided with what we'd found in our interviews from a previous phase of the study. As you can imagine, PPE came up a lot, not just the availability of PPE, but also that it didn't always fit people properly, which obviously can be very distressing. Risk assessments, which should have been done to everyone to make sure they had the safest possible working conditions, weren't always done, or they weren't always done properly, they weren't always followed up, they sometimes felt like tick box exercises. A lot of people were redeployed during the pandemic, obviously, but a lot of the times people were redeployed without any warning, or they were kind of redeployed and it wasn't a decision they could input and it was just something that was just kind of done to them. And finally, a couple of the people we talked to mentioned that they felt pressure to work harder than their white colleagues, and some people weren't properly supported by their manager during this really difficult time. So that was our questionnaire, and we sent that out to 22,000 people who had already participated in the NHS Check study, and it went out to them between February and October 2021. And this was our sample. We had over 4,500 people. Most of them were female, born in the UK, had clinical roles, and had a permanent contract. As you can see here, most of the sample were white British. As I mentioned earlier, around 20% of NHS staff in England are from ethnic minority groups, so we didn't quite get that. This isn't something I really want to shy away from. This is a limitation of the study, and it's a limitation of lots of studies. I will say that we did weight the data. We had access to kind of NHS HR data, so we were able to kind of bring this more into alignment with the population we were looking at, but it is just part of a kind of a broader problem in survey research where we need to think of ways to properly engage with ethnic minority people and earn their trust so that we can include them properly in data like this. But overall, 23% of the sample had probable depression and 18% had probable anxiety. And I'll just quickly go through some of our key findings. So in relation to PPE, we found that staff from black ethnic groups were more likely to experience PPE unavailability than white staff. 33% of our sample were redeployed during the pandemic, and of these staff from black ethnic groups were less likely to have a say about the redeployment. It was just done to them rather than with them. Staff from mixed and other groups were less likely to be forewarned about the redeployment, so it was just kind of dropped on them quite suddenly. And all participants, whether they were redeployed or not, staff from black and mixed other groups were less likely to understand their employment rights in relation to redeployment. In relation to bullying and discrimination, overall, a third of the sample said they were bullied by staff and a fifth said they were being discriminated by staff. But staff from black, white, or the mixed and other groups were far more likely to experience bullying and discrimination compared to white British groups. Now, obviously, this had health outcomes, so unsurprisingly, those who reported an unavailability of PPE or reported being bullied or discriminated against, that was associated with negative health outcomes, whereas things like being able to have a say in your risk assessment or your redeployment decision, being forewarned about your redeployment decision, or having like a basic understanding of your employment rights were all associated with positive health outcomes. So, in conclusion, during the pandemic, ethnic minority staff had a greater exposure to bullying, discrimination and PPE unavailability compared to white British staff. And just to kind of contextualise this just adds further burden to ethnic minority staff who are already at greater risk of excess infection, mortality and intensive care. And I know that this is all done like a few years ago and things have changed now, but this is just a smattering of headlines that came out recently just to highlight the fact that racism is still very much an issue in England and it's still very much an issue in the NHS and affects NHS staff. So a lot of the things that we kind of uncovered are still issues that we need to address today. And we can do that by protecting and supporting staff. We need structural changes to how ethnic minority staff are supported. We need to make sure their complaints are properly addressed, and we need to make sure there's greater representation in institutional decision making. And then I just quickly want to thank, this was a huge collaborative effort, and I just want to thank everyone on the core team, all of our co-investigators and our collaborators. Thank you very much.
Wonderful. Thanks so much, Rebecca. It's a hugely important work. I just wonder if I can get a show of hands. Do you want the air conditioning turning down? Yes. Sorry, I should have mentioned that at the beginning. So sorry that you've been sat feeling cold. We can now move on to our next presentation. A pleasure to introduce Professor Sally Marlow. Sally is Professor of Practice in Public Understanding of mental health research, and also BBC radio broadcaster, regularly pitching, developing and recording, presenting radio documentaries on mental health topics for Radio 3, Radio 4 and the World Service. Thanks, Sally.
Thank you. And I'm not on my phone, I just need to time myself. So I can multitask, but I'm not doing that. So thank you very much for inviting me to speak, and it's really great to be here. I've been part of the Centre for Society and Mental Health since its inception. It's something I feel really passionately about belonging to, and it's great to be here. I am coming on the back of 2 Titan research studies presented to you by Jay and Rebecca. I'm going to present to you something much, much smaller. This is a study that we did on mutual aid groups. And when I'm talking about mutual aid groups, I'm talking about the ones that arose during the pandemic, not mutual aid in other contexts which you might have heard. So, mutual aid, what is it? Well, this is the chap that first came up with the idea of mutual aid. He's a Russian. You'd never guess from the photo, would you? Peter Kropotkin. And he came up with this philosophy of mutual aid in response to the prevailing philosophy, which was around eugenics. So he argued for altruism and said that human beings were innately altruistic. If you had heard of mutual aid before the pandemic, you probably heard of it in the context of organisation theory, if you are at all involved in organisational psychology. More likely, you'll have heard of it in relation to addiction. So when we talk about groups like Alcoholics Anonymous, Narcotics Anonymous, we talk about these being mutual aid groups. In the COVID pandemic, mutual aid groups emerged in a completely new way. This is an article by Rebecca Solnit, who many of you might have heard of. She wrote the brilliant, sorry, can't help myself digressing, brilliant article, Men Explain Things to Me, which I highly recommend if anybody wants to read that. This is an article she wrote about the emergence of mutual aid groups, and they were everywhere in the pandemic. So what were they? They were small community groups where people had got together to provide basic services to each other. They were founded on the principle of solidarity, not charity. These were not charitable groups. These were groups where people were all in it, really all in it together. That wasn't just a political slogan. That is what these groups were doing. And more tangible and less theoretical, these were doing groups. These were groups that helped provide people's prescriptions, their groceries, anything that people needed, telephone support, people who were digitally excluded, those with computers were doing work for them, whatever was needed, and they were all grassroots. They were all organised locally with no resources coming from above. So Catherine Elzeby and Naomi Hartop, whose names you can see here, were both working with me on completely different projects, and both got involved with their local mutual aid groups, and came to me and said, not literally came to me because they weren't allowed to, on the screen they were beamed into me and said, Sally, individually they came to me and said, Sally, would really like to look at what these groups are doing and how they're doing it. So we applied to the Centre for Society and Mental Health, who allocated a little pot of money for small projects which were COVID related. So this was right at the beginning of the centre's inception. And we got around £10,000, so not a multi-million pound study by any stretch of the imagination. And we did a study to try and understand these neighbourhood-led mutual aid groups and what they were doing and how they were working. So, We approached 27 groups in 5 London boroughs and 4 wards in Leicester. Naomi was staying in Leicester at the time, so we were able to look at London and Leicester. Partnerships with those groups were what were really key to successful recruitment, because you can imagine those groups already had enough on their plate trying to fulfill people's prescriptions and get their groceries in without researchers knocking on the door and saying, oh, hello, can we talk to some of your people? We did manage to conduct 15 interviews in July and August 2020. That was with group organisers and with people who were in receipt of assistance from their local mutual aid group. Those interviews were all conducted online or on the telephone. Quite a lot of the people that we interviewed were digitally excluded, and we had to do them by phone. And what we found were that groups were indeed based on solidarity, not charity. They were based locally, often in a single geographic ward, so you would find that they mapped onto a local government ward. They provided rapid support to support neighbours with, double support there, sorry, provided rapid support to support neighbours with urgent material and health needs. And many groups successfully collaborated with community projects such as food banks. And, no spoiler alert, but you're going to hear a little bit more about food banks later. Now, this is also really important. The relationships that these groups had with local authorities were often difficult, though not always. And what happened after COVID, when we all thought, here is a new way of doing things, not just the mutual aid groups, here's a new way of being. This has brought the best out of people, not the worst. How are we going to take that forward? Did this get taken forward? No. So there were a number of meetings which I attended, London-wide meetings with key decision makers, still online, to explore whether local authorities could work in partnership with mutual aid groups. There's 2 enormous barriers to that happening. One is the red tape that comes with local authorities. So mutual aid groups just run themselves. You don't have to fill in 15 forms to get your groceries delivered. You don't have to put in a competitive bid against your neighbour because you have no groceries this week. They just run themselves, whereas local authorities are hidebound by red tape. And also there was an issue of trust. So, hearing from Jay and Rebecca about different groups where there are trust issues, those trust issues absolutely were mapped onto people's experiences of working with local authorities, of receiving local authority services in the past, of engaging with local authorities. So these 2 things were absolutely barriers to this work becoming something. Who knows what it could have become, because it didn't actually become anything. What did come out of it? One Guardian article. And a bit of a plug for the Sick Society podcast. Now, that's not to say that I think that this work wasn't worth doing, because I think it was. I think we learnt something new. I remain optimistic that even without the next pandemic, which Chris Whitty is singing from the rooftops we're all going to experience, that there is a role for mutual aid, and there is a role for this in our society. I can just say watch this space, because I don't have anything more to tell you about how that will move forwards. But the centre gave us the opportunity to explore it in the moment and to understand what the thing was. And that feels like it was a very, very valuable thing. So thank you.
Thanks very much, Sally. And that really begins to kind of move us a little bit away from the pandemic to thinking about what happened subsequent to the pandemic and some of the challenges that we faced post-pandemic. So it's now my pleasure to introduce Marina Kousta. Marina is a PhD student with us. Marina's research interests focus on the intersections of social and health policy, and is doing some important at work on food insecurity, food banks, mental health and welfare change. Marina, thank you.
Hi all, my name is Marina and I'm going to talk to you about, well, really a glimpse into one of my PhD chapters. And to put this in simpler words, I'm basically interested in examining the associations between different measures of food insecurity and mental health outcomes during the COVID-19 pandemic in the UK. And in the UK is very important because a lot of what I'm going to talk about today around food banks and other things actually really is based on the UK context. And that's important because food banks or other things like lockdowns were quite different in other countries compared to the UK. So keep that in mind. And just to give you a quick snapshot, why food insecurity? Well, food insecurity has been a massive public debate issue in the UK for many years now, particularly since 2010. And it's estimated that around 17% of households, which estimates to more than 12 million people in the UK, are food insecure. We know many pupils are eligible for free school meals, which is a means-tested benefit to children that come from low-income households. And at the same time, I'm sorry for not defining that abbreviation, FB stands for food banks. But I talked about food banks before. So food banks are kind of private food aid organizations that started rising in the UK since 2010. And they are really important in the food insecurity landscape of the UK because they provide short-term food to people in need. And we know that people with mental health problems, people with disabilities, and many other vulnerable groups are actually overrepresented among food bank users. Following from Greg's presentation, that accidentally falls quite nicely, since 2010, as I said, we've seen a rise in the distribution of food parcels from food banks, which falls at the time of austerity and an overhaul of the social security system in the UK. And you see that's when food supply parcels start to increase. And then, since my studies about COVID, what happens? So yes, it was already on the increase, but you see suddenly we have kind of a steeper increase during the COVID-19 pandemic that tries to fall around 21, 22, but then actually keeps being on the rise, and we're remaining in higher than pre-pandemic levels of probable food insecurity. And why is that important? So during COVID-19, where my data comes from and where is the focus of this research, there were many things that happened. That one report from the Food Foundation actually suggests that food insecurity may have even quadrupled during that time. The reason being that COVID, as we know, generated kind of new levels of vulnerability. We had newfound economic downturn, but at the same time, we had some occasional food shortages, and we also had shielding requirements and self-isolation measures, which meant basically for many people they were not allowed to go out of the house. For some vulnerable low-income populations, they were not able to travel to access cheaper food that they could afford. So all of this kind of came together, and that's why we see the increase. But this kind of research is important because, as we see, it still remains quite high. People in the post-pandemic world during cost of living crisis are still struggling, which is why I think this research is important. So from a lot of previous studies, we know that there is some type of association between food insecurity and mental health. Food insecurity might increase your risk of experiencing common mental disorders, anxiety and distress, but we also know that people with severe mental health disorders are at higher risk of experiencing poverty and food insecurity. The focus of this research, I want to say, I do acknowledge the bidirectional relationship, but the focus of what I'm doing is really about focusing on how food insecurity, the experience of poverty and this type of deprivation makes people suffer, how it gives rise to mental health disorders that can be a factor for many people to, pushing them further to poverty, making them unable to find employment, to get ways to get out of this kind of, self-perpetuating cycle of poverty. And there are many different pathways. I'm not going to stay too long on that, but I hope it's clear. And then, as I said, again, food banks, which are very important in the UK context. We have contrasting qualitative evidence as to how food banks could affect this relationship. Some evidence suggests that people, obviously, you get some food for a few days that releases you from some stress, because you can be assured for the next few days you might have some food to take care of. And also some people find support and a community in food banks, and they can talk about the issues they're facing. On the other hand, we know from a lot of qualitative studies that food banks are associated with really high levels of stigma, and people really use them as their last resort option, even people in dire need of them. So a bit about my method. As I said, it's a glimpse into my PhD chapter, so I'm not presenting everything, just my main model. So I used the largest longitudinal household panel study in the UK, Understanding Society, specifically the COVID-19 survey of the study. My main mental health outcome was the General Health Questionnaire 36, a continuous outcome where higher scores indicate higher probable mental psychological distress. I have a few different food security variables that I'm going to talk about in the next slide. My covariates, which I'm going to say, and statistical analysis, which is the main innovation of this study, that I'm examining this relationship longitudinally in the COVID context using these quasi-experimental methods that come from econometrics. And they're not perfect, and they claim a lot that they might not actually do, but they're, let's say, more likely to reach to the forbidden word that is a likely causal association between food insecurity and mental health. And no one has tried to use that before. So as you see, I have a few different food insecurity variables. The one is experiencing hunger. The other one is whether you access a food bank in the last 4 weeks. And then whether you had to skip meals and nutritious food. I have color-coded them so you can see the severity of food insecurity. The dark red, orange, I'm not sure how it looks, reflects more severe food insecurity, skipping meals is moderate, and then access to nutritious food is milder food insecurity. And I want to highlight that food bank is the only measure that is present across all 5 waves. So when I present in the next slide my results, just think that actually for food bank, for the food bank measure, I have a lot more information compared to the other food insecurity measures. I'm not going to bore you too much, but basically I did not find a lot of significant results except for people that used the food bank more than 4 times in the last month, where they scored higher, basically. The coefficient they scored, it was 2.3, I think, higher on the GHQ score, so they scored higher in the probable mental distress. And hunger, so people who experience hunger. So the most severe forms is when we see an association, and I didn't find any statistically significant association with milder forms. This could be for a few different reasons. One being the smaller sample sizes and fewer waves. The second being that, for example, the question on were you able to access healthy food in the last month, people may have been self-isolating, or maybe there were shortages. So yes, they were not able to access healthy, nutritious food, and they may have responded to this as well. So capturing kind of higher income people who would not necessarily experience any level of food insecurity otherwise. As I said, some conclusions, it confirms previous studies using kind of these novel methods that haven't been used before in this context. The most severe forms still show an association with poor mental health. Future research, we need to study better people that are food insecure and are often missed out from larger cohort studies to be able to understand their experience, because for better or for worse policy making, they always like their big data, and we need more of that to make sure that we can be convincing, which is sad. And the important thing, I think, as we saw, this is not COVID-based. The food insecurity and mental health relationship exists today, before COVID, after COVID, and it's gonna be worse as the cost of living of crisis is getting worse, and food insecurity, as we see, is rising. Just a limitations, obviously, a bit more technical, maybe boring, but still, I just want to say that, I cannot account for any type of time varying confounding, reverse causality. As I said, the relationship is likely bidirectional. I don't know how that's affecting, but also I cannot ascertain whether that is the truth. Also, the data, as I said, the sample does reduce for some of my models, and then it's really hard to assess to what extent the pandemic context had other influences into this relationship that I cannot capture or have not even thought of, or I'm unable to adjust for in my models. And yes, that's the end. Thank you so much.
Thanks so much, Marina. So we can move now to the final presentation for this opening session, and it's a real pleasure for me to introduce Haruka Goto, who is a research assistant on the Bridging Divides project here at the Centre, has done MSc thesis on Centre data, and is just recently started as a PhD student at UCL. So Haruka, please, thank you.
Okay, hi everyone. My name is Haruka Goto, and I'll be discussing about housing instability among adolescents in London and its association with mental distress among them. So let's begin with a brief background. So as many of you already aware that housing crisis in London is quite severe, and it's one of the causes is the imbalance between housing supply and demand. And so current survey shows that although the number of population and economy has been rapidly growing, but the housing constructions has not kept the pace. And also the average private rent per square meters increased significantly by 162%, which is very big jump. And also we know between 2019 to 2020, within 1 year, 23% of privately rented household has experienced relocation within a year. Also, we know this housing instability have a big negative impact on adolescent mental health. So, as you can see this left picture, so child poverty rate raised significantly by 38% after accounting for housing cost. And this situation gets worse for those living in private rented household and social housing. And also many papers, including systematic review and meta-analysis, indicate the strong association between mental distress and this relocation or residential mobilities. But we don't really know how many people, how many adolescents, how much population, proportion of adolescents are suffering from this residential mobility under this current housing crisis. And also, we don't really know about the housing situation, different housing situation by ethnic groups. So, one survey showed concerning racial disparity in differences of reason behind the housing residential moves. And this is a survey asking people the reason. So why did you move? And the red square is the answer of because landlord asked them to leave. And this green dots indicate black people, and blue represent Asian, and red is for white group. And as you can see, black people are far more likely to be evicted, so kicked out from landlord. And also there are disparity in financial situation as well. And so black or other minority ethnic group background people tend to have lower household, which could maybe have a different reason behind the residential moves. So this led us to hypothesize that residential instability situation in London differ among ethnic groups. So this is the summary of research gap we aim to fill in. So first question is how many people, what is the proportion of adolescents suffering from the residential instability? And second question is who is likely to move? And third question is how is the moving home associated with the mental health under the current housing crisis? So to fill in this gap, to address this problem, I used the data from Rhead study, which is Craig mentioned in his opening remark. And this is a school-based cohort study organized by the group in this center. And so this study is quite unique, and it's successfully capture the adolescent with diverse background, ethnic and social backgrounds. And I used self-reported data from 2016 to 2019. And yeah, I used several statistical methods to answer the 3 questions. So yeah, let's move on to the findings. And one of the striking findings is quite high level of high proportion of adolescent experience moving. So we found that 36.5% of adolescents in our sample reported housing moves at least one time within 24 months. And also surprisingly, we found that about 4% of adolescents experience more than 4 times of residential moves within 24 months. So this is really high, and this is high compared to the other European countries. So this white square represents the average number of moves for childhood, so from age 0 to 17. And for example, in Denmark, so the average number of moves is 1.4 times within 0 to 17 for 17 years. So considering this, we can now see the London's adolescent housing situation is quite severe. Also, we found the substantial disparity in ethnic differences in residential moves. And regarding sex and free school meals, which is an indicator of housing income, low household income, and IMD, which is a neighborhood representative level, we don't find any differences. But in terms of ethnicity, we found that compared to white British adolescent, almost all other ethnic groups has a higher likely to move, and especially Latin American, they were four times more likely to move compared to white adolescent, and also not Caribbean nor African black people and non-British white adolescent also double likely to move compared to white British. Also, we found that the family structure also has a different impact, and compared to adolescent living with both parents, adolescent living with single parents or non-traditional family arrangement has higher likely to move. So this shows some disparities among different backgrounds. Okay, so this is the last finding, and this is about association, and we found a strong association between residential moves and mental distress, and this is a consistent result with the existing findings. And yeah, and this association is stronger with number of moves, and we found each additional move is associated with 0.55 increase in mental distress level. So this is the summary. And so to sum up, we found that high number of people experience residential moves among adolescents living in South London. And also we found unfair burden by ethnic groups. And also we found a clear link between the residential instabilities and mental distress. And yeah, there were many limitations to this research. However, I really hope this kind of findings can prompt policymakers to address this really severe housing crisis. And yeah, so the mental health issues at the end. Thank you so much.
Thank you so much, Haruka, and thank you to all the speakers for a wonderful array of presentations and sets of research findings. I'm just very conscious that we've come up against time, that we were due to finish this session at 11:15, and it's now 11:17. And so we have a choice. We could either spend a few minutes with one or two questions, or we could move immediately to the break. Quick show of hands. Break. Quick questions. Okay. Let's have two questions. If you could, I wonder if the people in the panel could quickly come up, and we just take, if there are a couple of quick questions that anyone has. Yeah.
My question is to Marina about food security. Can you hear me? Yes, I can hear you. Because we also do some research on food security and eating disorders, and I was wondering if you had any data on diagnostics, any people with any mental health diagnosis, because what we know from eating disorders is that some people feel ashamed. Some people think that they don't deserve food, so they don't go to food banks, for example. Or people with larger bodies, they think that they will be judged, so they don't go. So I was wondering if you have any data, any observation, maybe for eating disorders or any other mental health diagnosis in general. Thank you.
Thank you so much. In all honesty, I haven't looked at this at all, primarily because I think, as I said, basically I come from a standpoint of poverty is making people suffer, and that's where we see an increase in common mental health disorders. If you look at other data, like the higher prescription of antidepressants in the most deprived areas in the UK and England, you can see, like I wonder, are we medicalizing poverty? Are we giving a pill to poor people? But actually what we need is systemic change in their daily lives, their work, their opportunities to improve the population mental health, but also reduce food insecurity and poverty. So I come from that standpoint that already excludes it. But that's very interesting because I think there are many subpopulations within food insecurity, and I've looked at this a bit for things like schizophrenia and bipolar, so not eating disorders, but kind of most of it psychological disorders, and I think there is a lack of data also because I do quantitative. The samples become so small, it's very hard to look at, but it's something I like to do in the future. To look more specifically and maybe look at the reverse way, how that may predispose you actually to experience food insecurity, if that makes sense. But I'm sorry, I haven't looked at this in detail.
Any other final questions? Yeah.
Hi, thank you very much for really brilliant presentations. I was just actually thinking about whether we know how far people move between their moves, because that would likely interface with how they're interacting with health systems as well. So just thinking about young people, CAMS waiting lists are really long and they're really complicated. Then moving between boroughs might further exacerbate kind of inequalities to access to healthcare.
Thank you. Thank you for the question. Actually, so we use the data only like self-reported and asking like whether they have moved or not. So we don't have like the data where they moved to, but we do have like postcode data. So we currently do not have a data like where to move and how long, how far they move to. But maybe in the future we can do something like, so like the distance can like associate with the like higher mental health or not. So yeah, that answer is like currently we don't have a data. We do have data, but we have not like examined the data yet. So thank you.
Thanks very much, Haruka. I feel like we probably need to bring things to a close so that you can have a bit of time for coffee and a break. And so it just really remains for me to thank all the contributions from Jay, Rebecca, Sally, Marina, and Haruka. And I wonder if everyone will be around over the break, so please do seek anyone out who you want to ask any questions of. But I think the key thing for me in thinking about how we move forward from here is we have a new government. And so we've heard all about the sort of impacts that all of the speakers have talked about. What can the new government be doing to be mitigating some of these sort of challenges? So with that thought, time for tea, coffee, and a break. Thank you very much.